The following is a paid commercial program. Views expressed belong to its participants and are not necessarily those of the management and staff of WRAL or Capital Broadcasting Company.
It's time for answers to your medical questions. And get an inside look at the latest in healthcare, medical technology, and treatments. This is Rex on Call.
Good afternoon and welcome to Rex on Call live on WRAL. I'm Kim Dean Holderness for Rex Healthcare. Did you know that colorectal cancer is the second leading cause of cancer deaths in our country? And did you know that it's largely the most preventable of the cancers? Today we're focusing our attention on colon health, advancements in colon cancer screening and surgery. If you're watching us live now and you have questions on this topic, call us. Your questions may be answered here live on our program by our experts. The experts answering your questions are Dr. Patel, a gastroenterologist with Digestive Healthcare, and Dr. Matthew Strouch, a surgeon with Rex Surgical Specialists. And there they are right there. To call us here at Rex on Call, just use the numbers on your screen. In Wake County, 919-744-3876. Outside of Wake County, call us toll free at 877-277-6252. If you're watching us as we're streaming live on WRAL.com, you can email us your questions to rexoncall@rexhealth.com. You can even find us on Twitter. Send us a question at Rex Healthcare, #RexOnCall. Now, here's the thing. If you're over 50, you need a colonoscopy. If you have other risk factors like a family history of polyps or colon cancer, you may need one even earlier. We talked with Dr. Seth Kaplan with Wake Gastroenterology about how the prep and procedure are easier than ever.
Our purpose in doing colonoscopies as a screening procedure is to find polyps when they're small before they can possibly grow and turn into a cancer. So our goal is to try to prevent colon cancer.
But there's a huge section of the population that should be screened, and they just haven't done it.
Most recent literature suggests that of the 52,000 colon cancers that were diagnosed within the last year, about half of those probably could have been avoided if patients had undergone screening procedures.
It's no secret the day before the colonoscopy will keep you close to the bathroom. But it's not as unpleasant as it used to be.
We have multiple preps to choose from at this point in time. Most of them, the volume is closer to half a gallon of liquid. There's a pill prep that's available in a certain patient population, depending upon their age, medications, and their own history. And the pill prep still needs some volume in terms of pushing the pills through, but it's still much less than that gallon of liquid that we used before.
No ifs, ands, or buts. You have to do the prep.
The quality of the prep is so important in terms of finding polyps because some of these polyps are quite small. Some of the polyps are rather flat, so they're not very elevated. The larger polyps are easier to see, but if it's a very flat polyp, we need to have a good quality preparation in order to be able to find it.
And the anesthesia is better too.
Probably one of the best benefits that we've had over the past 5 years would be the use of propofol. Propofol is an excellent anesthetic that patients do not remember the procedures whatsoever. There's no discomfort.
And joining us now is Dr. Patel and Dr. Matthew Strouch. So talk to us about the advancements in this anesthesia. How does it make your job easier? How is it better for patients?
Well, it's a huge advancement. Essentially, now you can have colonoscopy and you really do not feel anything. It's painless colonoscopy. It helps us because we have a comfortable patient who's relaxed, there's no resistance to the scope, and we can focus on looking for those polyps that need to be removed. So it really is painless. So the excuse of, oh, I'm scared of the pain from a colonoscopy is no longer there.
Okay, and we were talking a little bit about lifestyle and how you think that might play a part. Talk to us about, you said you spend a lot of time with your patients talking about food and diet.
Oh, it's so important. You know, any illness that we talk about, we now have to talk about global health. And one of the important things is diet. Diet is so important. And with colon cancer, we now know that too much processed meat, not enough fiber, obesity, diabetes, smoking, lack of exercise, all those are important things that are associated with a higher risk of colon cancer. So I told patients eat lots of fruit, blueberries, blackberries, pomegranates, all those things contain antioxidants that really have been associated with a reduced risk of colon polyps.
Okay, good to know. Now, Dr. Strouch, what are some of the surgical advances with treating colorectal cancer and these gastro issues?
So some of the largest advances nowadays are really approaching tumors in a more minimally invasive fashion. there's clear evidence that laparoscopic surgery for colon and rectal cancer is the same outcomes as with regards to survival. However, the functional outcomes, getting patients out of the hospital quicker, less pain, less issues with wound infections and things of that nature, are clearly better with laparoscopic surgery.
And what should a patient be asking their surgeon before going in about having a surgery in this area of their body?
Sure. The same principles with multiple other areas of surgery. Really, I think the more people do of a specific surgery, the better their outcomes tend to be. It's clear, there's studies in pancreatic cancer with this, and in the same thing holds true for colon and rectal cancer. So I think it's important to know how many of these cases does their surgeon do in a year? Do they have a special interest? Do they focus on this? And do they try to approach things laparoscopically if possible? And how often are they successful in completing things that way?
Okay, we've already had some emailed questions come in. This is a 52-year-old woman, postmenopausal. She had a polyp removed 2 years ago with a colonoscopy. Her doctor said she doesn't need one until she's 55. But now she's saying she's having her stomach is usually noisy after she eats something, and she feels sick or nauseous after eating dinner. Should she be getting a colonoscopy sooner?
Not necessarily. If she's had a good quality colonoscopy and her bowel prep was good, and that polyp was not regarded as a very high-risk polyp, 5 years is the recommended interval. The other symptoms may be related to other things. She might be intolerant to something she's eating, so reviewing her diet. And I think talking to a doctor to really tease out what could be causing those symptoms is important.
Okay, and how often should I have a colon test after finding out you have ulcerative colitis?
That's a very good question. It's not so straightforward in an answer, but essentially ulcerative colitis is one of the risk factors for colon cancer. And we know that if you've had ulcerative colitis for more than 7 years, you should go onto a surveillance program. And most people are performing colonoscopy about 2 or 3 years, every 2 or 3 years after you've had ulcerative colitis for a defined period of time.
Okay. Another quick question. I've been told I need to undergo all virtual colonoscopies in the future due to many complications in the past. The question is, if they see something, how would they get it with a virtual scope? How will they get it out?
Yeah, that's another good question. Virtual colonoscopy is essentially a CAT scan, and the CAT scan looks at the colon in a three-dimensional picture, and you get a fairly good look at the colon. It can miss small polyps. But the question is that if something is found on a virtual colonoscopy, you have to have a colonoscopy to remove it. I think in this situation, what they want to make sure there's no large, high-risk polyps that really need to be removed and take that risk of doing the colonoscopy.
Okay, but it's your opinion. These virtual colonoscopies are not as effective as a more traditional one.
Yeah, it's controversial. Some people do recommend it, but there are issues. It can miss small, flat polyps. There is exposure to radiation. And if something is found, you need the colonoscopy. So we still feel colonoscopy is the gold standard.
Okay. Our operators are really busy taking your questions. We can hear them over there. In Wake County, give us a call, 919-744-3876. Outside of Wake County, call us toll-free, 877-277-6252. If you're watching us as we're streaming live on WRAL.com, you can email us your questions at rexoncall@rexhelp.com. Find us on Twitter @RexHealthcare, #RexOnCall. Give us a call, give us an email, send us a tweet. We'll be right back. Welcome back. This is Rex on Call live on WRAL. Today we're talking colon health. As you're calling in with those questions, here's some more information on how Rex is improving patient care. For patients with gastrointestinal disease that requires surgery, there are minimally invasive options. And at Rex Hospital, doctors are once again leading the way in streamlining patient care. Michael Campbell makes his living as a chauffeur, running a very successful car service. About 6 weeks ago, a pain in his side became unbearable. He completed his scheduled calls, then called the paramedics.
I felt like somebody was sticking a needle in you, and it felt like a heavy brick.
Dr. Yale Podno says Michael suffered from diverticulitis, a condition caused by sacs in the inner lining of the intestines that became inflamed or infected.
he would need surgery.
I was in so much pain, yes. I was ready to walk myself to surgery.
Historically, that was done through big incisions and a long recovery. But as you see from Michael, he's a very active guy, and as a self-employed person, he doesn't have the luxury of having a lot of time off.
Dr. Podnos performed a minimally invasive surgery, and Michael was back to work in a matter of weeks. It's part of the patient-focused care from Rex surgical specialists. In fact, Dr. Podnos is part of a new gastrointestinal multidisciplinary care program at Rex Hospital.
What it does is it brings together all the specialties that we have, oncology, so radiation oncology, surgical oncology, medical oncology, along with Dr. Strouch, our colorectal surgeon, and also the pathologists and the radiologists. So really everybody who treats these patients with GI diseases all in one room at one time, and we can formulate plans and get everybody's expertise together.
This type of program helps streamline care for oncology patients.
Instead of having to do phone calls, that takes a lot of time, it's one-stop shopping, it's efficient. So actually, there's been a lot of research into these types of things that's shown that these have not only increased the speed to which patients got care, but also the quality of care, and it increased outcomes, made patients healthier.
And Dr. Strouch, I think we saw you in that video there. I think you were in that room. So here's a question regarding surgery. This is from Sally in Durham. Her husband is having a portion of his colon removed due to precancerous lesions. What are some of the effects that he may need to be concerned about after the surgery?
So it really depends on what part of the colon's removed. Typically for right-sided lesions, I tell patients that actually after they recover from surgery, from a bowel standpoint, they tend not to have too much of a change in their bowel habits. Potentially they might have one more bowel movement per day. Left-sided lesions, it's pretty similar. Sometimes we deal with a little bit more issues in getting their bowels regular after that, and some things like fiber can really help to avoid clustering of stools and keeping things regular. But the biggest thing recovering from surgery is their energy level, their strength, and getting back to their activities of daily living, which takes, I tell patients, they're really not back to normal until about 6 weeks after surgery.
Okay, that's good to know. Okay, if you have diverticulitis, do you have to have surgery?
No, actually, there's a lot of emerging evidence that you don't. Certainly for first episodes or even second and third episodes, you don't necessarily need to. There are times, and everyone knows, people who come in very sick from diverticulitis and sometimes requiring urgent emergency surgery. But for the most of the people that come in with some recurrent episodes of diverticulitis, we often can manage them non-operatively, put them on high-fiber diets, and avoid them with having recurrent episodes. And it's important to get checked out and talk to your physician about it, because there are definitely patients who will benefit from having surgery to reduce their incidence of recurrent episodes. But the current standard is on the range of three past episodes.
Okay. This is from Arsene Henderson. What are the symptoms of colon cancer?
Okay, that's a very good, important question. The most common symptom of early colon cancer is no symptom. And that's why it's important to get screened, even if you have no symptoms, and specifically if you have no symptoms. Unfortunately, only about 40% of colon cancer are discovered in early stage. And remember, early stage colon cancer is potentially curable, so you want to find them early. And the problem with early stage colon cancer is that you have no symptoms, which is why we have a screening program.
Oh, okay, and this is from Sean. When I go to the bathroom, I have blood in my stool. What causes this?
Lots of causes of blood in the stool, but that is a very important sign that you should get your colon checked out. There are lots of benign causes, such as hemorrhoids or inflammation in the colon. Diverticulosis can do that, but polyps or colon cancer can do that. So persistent bleeding from the colon definitely needs to be evaluated.
Okay. Coming right up, we'll be answering more of your questions. Give us a call. Those numbers are right there on your screen. Stay with us. Welcome back to Rex on Call live on WRAL. To reach us, call us at 919-744-3876 in Wake County. Outside of Wake County, toll free 877-277-6252, or you can email us those questions. We've got a stack to get to. Let's have it. This is from Maria in Raleigh. Her husband died in 1988 from colon cancer. Her daughter's 35 and wondering when she should get a colonoscopy.
Well, Maria, thanks for asking that question. Family history of colon cancer does increase your personal risk of colon cancer. So the usual recommendation, depending on the age that Maria's husband was diagnosed with colon cancer, that first-degree relatives start colon cancer at around the age of 40. But usually it's 10 years younger than when that family member was diagnosed.
Okay. This is from Betty in Newton Grove. She had a colonoscopy. She's 55 years old, and she had difficulty with the procedure. Is there something new she can avoid to avoid the 3 preps?
Yes, there are. Different people have different responses to the bowel preparations, but now the bowel preparations are getting better. Sometimes it's better when people have difficulty to start prepping slowly, 4 or 5 days prior, and watching your diet prior to the preparation, and that makes it easier. But discussing that with her gastroenterologist that she has difficulty can certainly help.
Okay, this is Sabrina. She has diverticulitis. Does this mean that she's more prone to cancer?
No, diverticulitis has not been associated with colon cancer, but when someone has diverticulitis, particularly for the first time, sometimes we look at the CAT scans and we want to make sure that there's no other cause that looks like diverticulitis.
And then,
okay, go ahead.
if
Yeah.
I could add one thing to that. So after patients have had an episode of diverticulitis, we typically recommend a colonoscopy after they recover from their episode of diverticulitis, just because sometimes, as Dr. Patel was saying, you can't necessarily tell the difference between a diverticulitis and cancer. So it's a pretty standard recommendation.
Oh, okay, good to know. Okay, this is from Francis in Roxborough. If I'm constipated, could that be a sign of colon cancer?
The most important thing is that if it's a change in bowel habit, if you've had a normal bowel habit and all of a sudden you're constipated and things have changed, the stools are getting thinner, or you develop diarrhea or bleeding, that's something you should talk to your doctor about. The change in bowel habit is important. Constipation can indirectly be related to colon cancer, yes.
Okay, this is from Ross in Raleigh. Can I have a colonoscopy with a history of inguinal hernia? What are the risks?
Yeah, I mean, there shouldn't be any increased risk in having a colonoscopy with the prior inguinal hernia surgery.
Okay. John from Henderson, his dad died of prostate cancer. He's 45. Should I wait until 50 to have a colonoscopy? Is there a relation between prostate and colon cancer?
No.
Okay, so he could wait till he's 50?
Yes.
Okay. Pat from Dunn, his son is 42 and had a colonoscopy with family history of colon cancer. Her sister has polyps. Now, at what age in that family with a history of polyps and colon cancer should they start getting their colonoscopies?
At age 40 at the latest.
Okay.
Again, it depends on the youngest person who was diagnosed with colon cancer. And earlier, if there's any suggestion that what we call a familial colon polyp syndrome or colon cancer syndrome. There are some families that have a very high risk of colon cancer called familial adenomatous polyposis, or Lynch syndrome is a separate syndrome, and that's something to talk to your doctor about. Those family members start screening at a much earlier stage, sometimes in teenage years.
And we were talking about the rate of colon cancer has in younger folks has really risen.
Yes, if you look at the national database, the incidence of colon cancer has actually gone down on average, about 20 to 30% over the last few decades. But the fastest rise in rate of colon cancer is between the age of 20 and 29, and that should not be happening. And environmental factors might play an important role here. So diet. Yeah. Healthy lifestyle, so important.
Get that junk out of there. Okay, this is from Jennifer. She's 35 and she had severe Crohn's disease at 17, had a colonoscopy a year ago and shows no signs of Crohn's disease. Yeah. Is it possible to heal yourself of that?
Crohn's disease is one of those diseases that can get active, can get dormant. That means that she's inactive, but she certainly can flare up in other parts of the bowel as well. So keeping close follow-up with her gastroenterologist is recommended.
Okay, great. Now we're going to have a final round of questions after this break. This is Rex on Call. Stay with us. Welcome back to the show. This is Rex on Call, and we're taking a final round of your questions right now. This is Carol. She had hip replacement and would like to know if she needs an antibiotic for colonoscopy.
Good question. Hip replacement is something that can get infected. Now, usually if we've got an elective colonoscopy, we'd like to wait at least 6 months. And after the 6-month period, we generally don't give antibiotics unless that hip has a history of being infected.
Okay, this is from Carol. What's the best method to treat hemorrhoids on the outside?
So hemorrhoid disease can be either internal disease or external disease. And there's a large amount of different treatments for them. The best treatment typically for starters is dietary changes and high fiber. If people are having bleeding, there's a number of different treatments. Some can be done in the office and some can be done in the operating room. For external hemorrhoids, If they're truly external hemorrhoids, really the only treatment is surgery. And this is something that you need to have your doctor evaluate to see what would be the best potential treatment.
Okay, this is Geneva from Sanford, gastric bypass patient. Is it more difficult for her to have a colonoscopy than somebody who has not had gastric bypass?
Really the gastric bypass procedure involves rearranging the foregut and some of the small bowel from the stomach, so it doesn't affect the colon. People that have had that surgery can have colonoscopies without a problem. Upper endoscopies could be more of a challenge with their, but.
This is Ida. She says she's getting a colonoscopy every 10 years. She's had polyps. Her mother and great-grandmother died of colon cancer, but her doctor says she really doesn't need one more than every 10 years. Do you disagree?
It depends on what type of polyps she's had. If she's had precancerous polyps, probably every 5 years. If she's had colonoscopies where she never has any high-risk polyps, then 10 years is probably reasonable.
Okay. This is Betty from Oxford. Can you have a colonoscopy if you're on chemo for breast cancer?
Generally, yes, as long as you're not having any side effects from the chemo. Sometimes we wait for the colonoscopy to be done after the chemo is finished. If there's an urgent need for the colonoscopy, then we would do it.
Okay. This is Linda from Selma. Any way to prep besides all that liquid?
Well, there are many new preps now, and talking to your doctor about it is definitely a good idea. But a good prep is a little bit inconvenient the day before, but it's so important, especially when we don't want to miss the small flat polyps. We want to clean as colon as possible. That way we can be as effective as possible.
Okay. This is from Bobby. Everything she eats causes cramping, and she says her stool are actually a white in color. What could this be?
Well, that could be several things, but I think, again, talking to a doctor, reviewing her diet, sometimes restricting the diet, and looking at how long she's had these symptoms and what other associated symptoms there are. That's a fairly complex answer, but I think she does need to follow up with that.
Okay, and this is somebody, we've got a lot of questions about this new medication for sedation, and they want to know, they said they had problems with the previous colonoscopy. They woke up during it. So talk to us again, remind us again about this new medication.
So the type of sedation we now use is propofol sedation, and that is a very good, safe sedation if used by the right professionals and in the right situation. And patients have what we call conscious sedation, so they're still breathing on their own, but they're asleep. And we can adjust the doses during the procedure. And we rarely have patients waking up in the middle of it, and if they do, they fall back asleep very, very quickly. The older type of sedation, we sometimes did have difficulty with some patients trying to sedate them. So this new form of sedation really has made a big difference.
Okay, would that help somebody like Shelley from Roanoke Rapids? She says she has intestinal problems, can only have a partial colonoscopy procedure, and the rest has to be completed by a hospital with barium enema and x-ray, and has a lot of pain. With something like that, would that?
It might do. If she has good sedation and it can help the gastroenterologist to get around, obviously she has a very difficult colon, which is probably very twisted, and she may have some scar tissue, and that may be the issue. But yes, sedation will help.
Okay, and now this is another question about that. His brother had a colonoscopy and had troubles coming out of the anesthesia. Now he's scheduled for a repeat colonoscopy. Is this probably new colonoscopy or new anesthesia, something that could probably...
Yes, it's very short acting, and so we generally don't have the nausea afterwards. We don't have what we call a hangover effect. Mm-hmm. The older ones, sometimes you'd have those effects that would last hours.
Yeah, I can testify to the new sedation. I woke up and I was actually mad because I wanted a nap afterwards. But I woke up and I felt like I could have driven home. Okay, and how...
Please don't.
Yeah, I know, I didn't. Now, how often should you have your colonoscopy if you're having digestive issues? Real quick. This will be the last
If it's a
question.
screening, 5 years or 10 years, and digestive issues could be lots of other things.
Okay. Now we want to let you know about something. Check out Rex's Facebook page. Check out our website. They are collecting expired and old medication this weekend on Saturday, and all that information is on their website, but that's a really important service. Check that out. And as always, consult with your physician about any health concerns. Please join us next month, April 15th. We'll be talking about women's health issues, how to look and feel your best at every age. That's Monday, April 15th at 1. Email us your questions on women's health ahead of time at rexoncall@rexhealth.com. See you next time.
This has been a paid commercial program. Views expressed belong to its participants and are not necessarily those of the management and staff of WRAL or Capital Broadcasting Company.